Hello, everybody. It's great to have you with us at this time of the morning, or I don't know, wherever you are and the time that you are in. Thank you for joining us. Today's morning program is presented to you by Department of Prosthodontics. I'm Dr. Farzaneh Farid, the moderator of this program. On behalf of my colleagues, I welcome you to our program. The program has two parts. Part one is a PowerPoint presentation and with a movie presentation, and part two after break is again a PowerPoint presentation and movie presentation. At the end of each session, we have, at the end of each part, we have time for question and answer. Our topic we chose to talk about is clinical guidelines for restoring endodontically treated teeth, because in your career in the future, you will see a lot of teeth that have root canal therapy. Teeth with infected or inflamed pulpal tissue should go for root canal therapy. The first step is to make a access cavity to the pulp chamber, removing the devitalized and necrotic pulpal tissue, cleaning and shaping of the canals, and filling the canals with material that most often is gutta percha. The last step is restoring the coronal part of the tooth. This restoration is important, perhaps as important as a good quality root canal therapy, because if the marginal of the restoration is not tightly sealed, there would be recurrent caries, recurrent apical lesions, reinfection of the canals. Also, the design of restorative material restoration should protect the remaining tooth structure from future fracture. Let's see different scenarios, different cases with teeth with root canal therapy. Here we have a tooth with just access hole or access cavity. The remaining tooth structure is thick and sound. Here we have an occlusal cavity larger than access cavity, and the second premolar has marginal ridge loss plus to occlusal cavity. This tooth has lost more than half of its structure. Now, the question is, shall we follow one protocol for restoring all these different cases? Clearly, it's not. So what kind of options do we have for restoring root canal treated tooth? If the cavity is small and remaining tooth structure is thick enough, more than 2 millimeters, it is possible just to restore it with direct restorative materials. If the cavity is larger, however, more than 50% of tooth structure has remained, we should restore it with indirect restorations, and we should cover the cusps. It is not enough to just restore it with direct restorative materials. We will talk about it later. When the cavity is large, however, we have some tooth structure all around. We can build up the cavity with restorative materials and then prepare the axial walls for full coverage or partial coverage crown. When the remaining tooth structure is not enough for retaining the coronal restoration, we should use intraradicular space for and put a post inside it to retain the coronal restoration. Here, the post and the core that is formed around the coronal part of the post plus the remaining tooth structure make the foundation for the final restoration, that is a crown. So the purpose of post-anchor treatment is retention of coronal restoration. Does post reinforce the tooth structure? No, it doesn't by itself. However, with a post, as you see in the picture, lower picture, the forces, occlusal forces, are concentrated around the margin of the restoration. When there is a post inside the root canal, and the forces are distributed all along the post, so it is not concentrated at the margin, and the risk of fracture lowers a lot. So when there is a small amount of remaining to the structure coronally, it is definitely recommended to put post and core. Let's talk about more about the intraradicular or intercanal posts. They may be custom made or prefabricated. And the custom made posts are shaped according to the shape of the canal of the patient. And the post and core are attached to each other in one piece and have the same material. They may be cast or may be made by CAD/CAM techniques. However, for making and cementing the post and core, custom-made post and core, you need 2 sessions. One session for fabrication of the post and core pattern, and this next session for cementing the cast or CAD/CAM made post and core. There is another way, another main type of posts. They are prefabricated posts. In this kind of post, the canal of the patient is reshaped according to the form of the post. So this is the main difference between the custom-made post and prefabricated posts. The other difference is that the post and core have different materials, and they should be attached to each other by means of mechanical or micromechanical retentive elements. As you see at the lower picture left side, the mechanical element here is serrations or threads. For the fiber posts that have a smooth surface, and the retentive element is adhesive materials. So we use some retentive element to attach the core to the post. And this kind of post and core fabrication is cheaper than the custom-made posts and can be done in one session only. So this is an advantage over the custom-made posts. For post and cores to be able to tolerate or resist lateral forces, especially when the post and core have 2 different materials and are attached by means of mechanical or micromechanical elements, it is important to have something that could resist lateral forces. This thing is actually the remaining wall of the tooth structure. Here you can see it. When you have 2 different materials for post and core, and there's the risk of separation of them or breakage of the post or detachment of the post from the canals, it is better to have longer remaining wall of tooth structure. This wall is called ferrule, and the part of restoration, the metal band around this part of the tooth that is coronal to the finish line, is provides something that is called Ferrule Effect. Ferrule Effect is like the effect of rings around barrels that prevent the planks to be separated. The longer the Ferrule effect is, the longer the remaining tooth structure height is, the more the tooth is resistant to the lateral forces. So if you are going to use Now, fiber posts. The first fiber posts that were introduced So we have carbon fiber posts that are very strong but are dark, and the attachment of the carbon fiber post to composite was not strong enough. And the tooth-colored posts were introduced. They are reinforced by actually glass fibers or quartz fibers, and some of them are translucent. So routinely nowadays we mostly almost 99% fiber posts than glass fiber posts or quartz fiber posts, not carbon fiber posts. As we talked about, for using fiber posts, you have to reshape the canal of the patient according to the form and size of the fiber post. So you have to use burrs, special burrs that are delivered with the fiber post, and they have matched size with the post that you are using. And the fiber posts have to be attached or bonded to the tooth structure with resin cements only. We can't use any other cement because the best result is with resin cements. Now let's talk about post space preparation, especially for custom-made posts. We have a movie presentation with my that is narrated by my colleague, Dr. Mahmoudi, after this presentation. And right now we just talk about them. What parameters we should consider when we are designing the post space? And the important parameters are length, diameter, and the number of canals. The post length is very important because it makes the retention. For us, the longer the post, the more retentive is the post inside the canal and the superstructure. However, the limiting point is the remaining apical gutta percha. If it shouldn't be less than 4 to 5 millimeters. The exact, the least minimum remaining gutta percha is 3 millimeters. Less than that, everything for the root canal therapy is will be in danger. Will be put in danger. So it is better not to go more than 2 meters more to the apical side. So 4 to 5 millimeter of gutta percha should remain. The other measurement could be 2/3 of the length of the canal, 3/4 of the length of the canal, or the post should be as long as the crown that we put on the tooth. And what about the diameter of the post? The larger diameter will have more retention. However, we should keep in mind that if we enlarge the canal space too much, there would be the danger of fracture of the root, vertical fracture, or even during enlargement, there could be perforation of the root area. So, and the parameter is not to enlarge the coronal part more than 1/3 of the diameter of the coronal part, and at the apical part, at least 1 millimeter sound dentin should remain around the post. In my opinion, it is better not to enlarge the canal if you think that the root canals are shaped very well. There's no need to re-enlarge it for any reason. So it prevents the danger or protects you from the risk of perforation or future fracture of the root. How many roots should we use, especially in multi-rooted teeth? For maxillary teeth, molars, just palatal root is enough to use because it is wide and straight. For mandibular molars, it is distal root is enough because it is also wide and straight. We have maxillary premolars, first premolar that has most of the time 2 roots or at least 2 canals. The point is sometimes we should use the canal that is straighter and longer. Sometimes the canals are not, actually we can't use the canal space as long as we want because the apical part is too narrow. In these cases, we can use 2 canals. The coronal part of the 2 canals, about half of the root, and make a core 2 posts in 2 canals attached to 1 core. This is almost routine practice about maxillary first premolars. What about the molars? Sometimes when the remaining tooth structure is very short, you have to use 2 canals even for molars. In these cases, you can make 2-piece cast posts or for making these kind of cast posts. If you use key and keyway element portion of the 2 cores inside each other, it is better to send the impression of the tooth to the laboratory, and then laboratory makes it for you. You see, this is the key, and this is the keyway. They are attached to each other and cemented simultaneously inside the tooth structure. And in this way, you have used 2 canals, especially when 2 canals are not parallel to each other, have angulation that you cannot bring out the post pattern is with 2 attached posts at the same time. So when the canals are not parallel to each other, have a lot angulation with each other, it is better to use this kind 2-piece cast posts. This is another form of 2-piece cast posts, and the post and core is attached to one of the posts, and another post is placed inside them, again at the same time. But as you see, the form is different from the former one. It can be done by you in the clinic. Now, when we want to choose the treatment technique, what parameters we should keep in mind? The remaining tooth structure is one parameter that we talked about. The type of the tooth is important because the direction of force in anterior teeth is different from posterior teeth. In anterior teeth, the direction of force is laterally, but for the posterior teeth, it is vertically, and at the center of the tooth, almost where there is access cavity. And so the posterior teeth are in danger of splitting and fracture. The other important parameter is force factors. It means that how much force, how much is the masticator forces of your patient. Is a patient a young musculature person, have strong muscles, have perfunctional habits like bruxism or clenching? These factors are important to consider during choosing the treatment technique. If these factors are present, it's better to use more radical treatments than conservative treatments. Already, here we have just access cavity hole and the sound enamel and dentin around it. This kind of tooth cavity here with a small size can be restored just by direct restorative materials. However, look at this one. Again, we have just a cavity, but the cavity is larger. And as you see here, the light passes through the dentin. So it means that the thickness of the dentin is not good. It is narrow, it is thin. In these cases, just restoring the cavity with direct restorative material is not enough to prevent the fracture of the tooth during mastication. So it's better to restore it with post and core crown. It may be, you may hear that you can put post and put direct restorative materials around the post at the coronal side. However, imagine that you have put composites here and then you want to shape the palatal side of the tooth. Most of the fiber posts will be reduced or and become very thin. In this situation, and the fiber posts will not tolerate or cannot resist any lateral forces. So if you think that remaining tooth structure is not enough to tolerate lateral forces, it is better to use post and core crowns. Now the question is, if I use post and core with metal alloys, can I use full ceramic restorations? It depends on the color of the post and core that you are using and the type of ceramic. If the color of post and core is light yellow, like noble and high noble alloys, and the full ceramic crown has an inner part layer that is opaque, you can use metal post and core and a full ceramic crown on it. But if you are using base metal post and cores and that are dark, and you want to use a full ceramic with translucent oval layer, it's better to cover the coronal part of the actually the core with an opaque material. It could be opaque composite or the opaque that we use in metal ceramic restorations. And the inner layer of the ceramic restoration should be thick enough to cover all these colors, the opaque layer and the inside color, if it can be seen, I mean the color of the post. It is true about discolored teeth too. You see we have a deep discoloration of the tooth. If you want to cover it with full ceramic restoration, the inner part of the ceramic restoration, I mean the core, should have enough thickness to cover the color of the tooth. For zirconia restoration, it should be at least 0.5 millimeter. For other restoration like lithium disilicates, it should be 0.8 millimeters at least. And then you have you can have a translucent layer over this core and to make it more aesthetically pleasant. However, if you you have actually the color of the tooth can be seen through the gingival, and gingival type is thin, it is better to use metal ceramic crowns, because metal ceramic crowns can be made thin at the margin. But for full ceramic restoration, to have coverage of the discolored tooth, it must be very thick. For the posterior teeth, as you see, after preparation, we have lost the roof of the pulp chamber, so we have lost the integrity of the tooth. If the remaining part of the tooth are not strong enough, there is danger of fracture or splitting of the cusp because of the forces that is imposed to the tooth by opposing cusps. Just restoring the access cavity with direct restorative materials is not enough, because the opposing cusp, the forces from opposing cusps make the actually wedges in the restorative material inside the pulp chamber and makes the cusps to break, break the cusps. So what we should do is to cover the cusp. That is why we call it cusp coverage. We reduce the cusp, make a flat seat, and then we restore the tooth. In this situation, when the opposing cusp imposes loads to the restoration, it cannot be wedged because it is tolerated or resisted by the cusps, remaining cusp. They don't let it to be wedged. That is why we say that for posterior teeth, most of the time we have to have we should have cuspal coverage. Now the point is posterior teeth are not the same. Premolars are different from molars. Even upper premolars are different from lower premolars. Upper premolars are long and thin. It means that the buccolingual dimension is more than mesiodistal dimension. So if you have an access cavity, it could be very small or very thin remaining tooth structure to withstand the occlusal forces. If the access cavity is small and you know that the remaining tooth structure is enough, you can just restore it with direct restorative materials. However, if there is a large cavity, occlusal cavity, and loss of marginal ridges, it is better to have cuspal to have full coverage. It means that all around the tooth should be prepared and covered. In these cases, because the remaining tooth structure after preparation is almost always very thin, it is better to put posts inside the canals too. However, for the lower premolars, the first lower premolars is very similar to the canine. So if the direction of force is like anterior teeth, you can behave it like anterior teeth. It means that there's no need for cuspal coverage. It is just filling the access cavity. But if it is, the direction of force is toward the access cavity, it is better to behave it, to treat it like posterior teeth and have cuspal coverage. And the second molar is like a small molar, and as you see, after access cavity preparation, you have enough tooth remaining tooth structure. So these can be actually just covered with cusp coverage. There is no need for preparing all around the tooth and putting a partial or complete crown. Now, what about molars? As you see, molars, again, you may have just a small access cavity hole, and it can be restored with direct restorative materials. If you have access cavity hole plus a marginal ridge loss, you should think about and you should measure the thickness of the remaining tooth structure. You may just have a cusp coverage with indirect restoration. If the remaining tooth structure is thin, you may think about have a full coverage crown. For these situations that the remaining tooth structure is almost absent, it's better to have post-core crowns. So for molars, it is not enough, like all the posterior teeth, it's not enough just to use direct restorative materials. We should have classical coverage. Can we build up the tooth with direct restorative materials like amalgam? It's possible, but it is recommended to have full coverage over it after a while. It means that just amalgam built up is not the final restoration for the molars. We have seen it already. If you have a large cavity on the occlusal side, but you still have walls all around, you can build up the cavity and then put a partial or full coverage crown over the tooth. If you are using amalgam built up and then the crown, it's better not to extend the amalgam inside the canals, because if for some reason you have to remove the crown and amalgam, it is not easy to remove the amalgam that is extended inside the canals, because you can see there and there is a high risk of perforation. So for the posterior teeth, we talked about when we use direct restorative materials. Now, if you have a large cavity, but the remaining tooth structure is more than half of the tooth, and the remaining thickness is more than 2 millimeters, you can have indirect restorations with cuspal coverage. Recently, we call them Endo-Onlays. If you cover more of the tooth, it is Endo-Overlay. It means that you have a coverage of around. It is Endo-Overlay. So a part of the cusp, a part of the restoration goes inside the pulp chamber, and it is cemented with adhesive cement to the structure. In this way, we have actually we have a restoration without a post, and also we have cuspal coverage. These are called Endo-Overlays. And when you have just 2 millimeters of the crown or coronal part of the tooth over the gingival margin, you may put endocrowns. These techniques all are the same. They use for the intra-pulp chamber space for retention and the adhesion to the remaining enamel and dentin. And these crowns are made by CAD/CAM techniques. At the second part, we have a presentation for the indication and contraindication of endocrowns and how they are made with a CAD/CAM technique. There is a movie presented to you by my colleagues, Dr. Siadat and Dr. Nokar. So let's see what about if we have lost a lot of tooth structure. but we want to retain the tooth. We don't want to extract it and to put implant in its place. Like this situation, it is anterior tooth. Anterior tooth are not easy to have a good implant placement in them. From aesthetic point of view, from the margin of the gingiva. So it is highly recommended to retain, to keep the tooth as much as possible. As you see here, the ferrule is not enough. So we decided to expose more of the tooth structure. We have two choices. One is to remove the gingiva and bone from around the tooth to expose more to the structure. However, when you want to do a periodontal surgery, like crown lengthening, you can't do it for just one tooth. You have to extend it to all adjacent teeth. Like when you want to do crown lengthening for the lateral, you have to do for all 6 teeth, anterior teeth. So because the patient had good gingiva and everything was healthy, we decided not to use periodontal surgery. Another way is extrusion of the teeth. In this kind of treatment, in this technique, we bring out the root from its bony socket. We extrude the root, actually, or extrude the tooth. For doing that, we put a post, a prefabricated post, and cement it with a temporary cement inside the canal, and build up the shape of a lateral with composite, and put a wire here with a loop toward the incisal surface, and put the wire is attached, or the bar is attached by composite to adjacent teeth. A hook is placed inside the composite build-up, and then an elastic band, orthodontic elastic band, is wrapped around them. After 3 to 4 weeks, we had this form of the tooth, this shape of the tooth. It was extruded about 1 to 2 millimeter. Now we have enough ferrule. We put post and core and the final crown over it. Now the question is, if your root canal treated tooth is abutment for fixed partial denture or removable partial denture, you have to use post and core, and it is highly recommended to use custom-made posts and cores. Now, what about this question? Shall we restore teeth like this or extract it? It depends on how much the restoration of these tooth will last. And does it last just for 1 or 2 years, or for more than 5 years? If you think that it lasts more than 5 years, it worth to keep it. For keeping such a tooth, you may need to have crown lengthening. As we talked about, crown lengthening is not just for one tooth. You have to do it for adjacent teeth too. So you have to remove bone from adjacent teeth. Again, you should evaluate, does it worth it? Or if you remove the bone around this tooth, does it become, the height of bone decreases to the level that you can put an implant inside the extracted tooth if in the future you extract it. So then you should consider how much you should pay for retaining this tooth. If you should reduce the bone to the height that is not good for future implant placement, it is better to extract it and put an implant in its side. But if it can stay in position, even if you remove the bone, the remaining bone height is enough for future implant placement. You can keep it, and it will work along if you have good choice for you make a good choice for its treatment, considering all factors that we talk about, especially force factors. Okay, thank you for your attention. Um, uh, um, okay, if you want, we can have, we just have two questions. We can answer this question and then go for Dr. Makbari to show his movie. دکتر مقبلی اینجا هستن؟ میخواین ایشون شروع کنن یا میخواین؟ Still use amalgams for what? I mean for buildup of core buildup under the crown, for restoring the teeth, or for something else. Actually, yes, we still use amalgam for core buildup if it is necessary, and for restoration of the teeth that cannot be restored with direct composite fillings. In slide number 35, can we have a slide number 35? If we will not use periodontal surgery to the gingiva, how we can complete this procedure? Number 35. Orthodontic extrusion. As I talked later, we had orthodontic extrusion with the wires and all things that we talked about. I talked about. Actually we have two different way to expose more of the tooth structure. One of them is periodontal surgery, like crown lengthening, and the other way is orthodontic extrusion. Orthodontic extrusion are mostly used with anterior teeth and sometimes with premolars, but for the molars, it is not possible to use orthodontic extrusion. If again you have question, I can answer it. Can cemented custom-made posts withstand orthodontic extrusion force? Custom-made or prefabricated? Could we cement the cast post and core and then apply orthodontic extrusion force over temporary crown? Yes, it is possible to use cemented custom-made posts and cores. However, you know, when you fabricate the post and core before the extrusion, after extrusion, you should refine it. And sometimes after you refine it, you may lose the tooth structure around your post. So in my opinion, it is more conservative to make first the extrusion and then make the fabricate your custom-made post and core. Could we cement the cast post and core and then, it is possible you cement the cast post and core and then apply orthodontic extrusion over temporary crown. Yes, it is possible. In my opinion, it is better to do it after extrusion. What about cases when the coronal part of the teeth fractured subgingivally? Can we still restore it somehow? Yeah, it depends on how much it is fractured subgingivally. It is, can you extrude or crown length and to expose the fractured part, or you have to, or it's not possible. It depends on the end point of the fracture. Is it, do you still have some tooth structure that is possible to you to prepare it and put it crown over it, put a crown over it. For all of them, it's contraindicated in some countries, I don't know what do you mean of all of them. If custom made, I get it. Thanks a lot. Would you please explain what do you mean by all of them? Mufida Janina. Can you talk, Mufida?
Amalgam.
She means amalgam use. Yeah, amalgams are contraindicated because of the mercury, but we are still using it and we are still alive. I have amalgam fillings in my tooth. Okay, so I can say that anything. You can use other things for actually for build-up. You can use composites for build-ups and it's okay. Thank you, it's my pleasure. So let's see if there is any other question. Explain about the CAD cam?
Yes, this was the first question.
Where is the question? Okay, would you please explain the CAD cam more? You mean the CAD cam made post and cores or CAD cam made endocrowns? About CAD cam made endocrowns, we will have a PowerPoint presentation and movie presentation later. I don't know if you mean that one or CAD cam made post and cores. My pleasure, everybody. CAD cam made, it was the question of Gita. Gita, would you please tell me, you meant CAD cam made posts and cores or CAD cam made endocrowns? Okay, for CAD cam make post and cores, it is a new actually advancement in making post and cores. It is not much investigated or researched by literature. However, it is a possibility. The point is CAD cam materials, CAD cam make materials should withstand occlusal forces and also lateral forces. And during CAD cam making the post and core, there is a problem with the tip of the post. Most of the time, the technician object about the fracture or chipping of the tip of the post. Of course, it depends on the material that you are using. The materials that are not as strong as zirconia does not chip that much, but they are not as strong to withstand the lateral forces. Zirconias are very strong, but the chipping, especially in that narrow and thin measures in that size, and they have more a risk of chipping. Amalgam danger comes when you have many teeth restored with amalgam. Also, I read that not all clinics have the proper equipment to remove the amalgam later since it's toxic and needs special tools and careful removal. They said, yes, that's what I have heard. And but you ask me honestly if we are using amalgam still. Yes, we are using it still. And in TUMS, do you have these equipments or what are they? In the prosthodontic department, we don't use amalgam because we just do indirect restorative techniques. We put crowns and bridges. So I don't know in their operative dentistry part if they use amalgam, these techniques too or not. Amalgam filling is important when we want to make bridges. For bridges, no, we use custom-made posts and cores. Of course, we use amalgams under for the build-up. It has been in use in the past, and I think in many countries it is still in use. However, for routine, perhaps for routine restoration, it is not much in use. It is more used as nowadays more composites are more in use. I think in countries that you are talking about are Scandinavian countries like Sweden or something, somewhere like that, that they all use just composites for restoration of their teeth. And we had a webinar with someone from, I think, Denmark. And he said that they have composite filling, they re-restore the composite filling almost after 5 years. But for the amalgam fillings, you change the restoration almost perhaps after 20 years. So I think it depends on the countries and their concepts. I'm telling you, we all have used it all these times, and there wasn't a negative effect. Perhaps in countries like Scandinavia, with all that water that they have with lakes and rivers, they have a problem with the mercury that comes from amalgam after preparing amalgam restoration. Another question? My pleasure. Mafida, so I don't know who asked about CAD-CAM. Is your question answered? Oh, Gita, yes, Gita. You are welcome, everybody. Why some countries still use amalgam if it is dangerous? You can ask the countries that are using. I'm saying you, I have amalgam filling in my mouth. I had a tooth fractured recently. My dentist is a very good specialist, said that I can build it up with composite because it is difficult to have contacts with tooth adjacent teeth. It was not, if I wanted to have a crown over it, I should have a root canal filling, but she made for me an amalgam filling and it is working for me now. Yes, for 50 years or more. Many have more than 50 years. Thank you. Amalgam, yeah. I think it is better to say that amalgams have some advantages, composites have some advantages. It is important when to use them and where to use them. We should consider that. And don't forget that everything is in progress, is developing. If we could have a strong composite and a good adhesive, we can use composites in large buildups and cavities. But when it is not, when we are not sure about its strength and the adhesives, it is better to use silk amalgam. Yes, you know, because not just under the bridges. That is why I told you that for large cavities, we still use amalgams, because composites have, especially former composites, maybe they are not better. They have contractions during thermal fluctuations. It means that if you have contraction after polymerization and also during cold and warm materials drinks that you have expansion and contraction of the composites, and it makes that the bond to the tooth to be disgraded. It means degraded. It means that the composite little by little separates from the tooth, and then we have a leakage over in that area, a recurrent of caries, and also the bad smell that you are talking about. Yes, that's why it is recommended for large buildups to use silk amalgam. Thank you so much. When there is vertical root fracture, what's the best option? Extraction, or can we do hemisection and extract fracture root, then do post and core restoration? Actually, for a hemisection, you should have some criteria to do hemisection. The first criteria is you have a root trunk that is not much apical, and the distance between two roots must be enough to extract one root and keep another root. In the past, it was a very well done procedure. In the recent years, because you have to, when you put a post and core, you have to bridge it with the adjacent tooth, and the adjacent tooth is not restored. If it doesn't have any restoration, you have restored it with a crown. And everybody prefers to put an implant in its place rather than to have hemisection and to make a bridge with adjacent teeth. In recent years, hemisection is not done much, especially because the adjacent untouched and sound tooth should have to be prepared for crown. So if there is any other question, I will be there after Dr. Makoli's presentation. Thank you everybody for your being with me. Thank you so much. See you later. We are all familiar with conventional prosthodontics, how to prepare teeth, how to make impressions, the laboratory procedures and delivery steps. But like other aspects of our lives, prosthodontics is getting more and more digitalized. And being familiar with digital prosthodontics, especially CAD/CAM technology, is mandatory for an up-to-date dentist. That's why we have planned a short course in digital prosthodontics. Join our outstanding program at Tehran University of Medical Sciences School of Dentistry. Hello again, everybody. And Dr. Makoli is here. Dr. Makoli, my colleague, is the head of the Dental Technology Department and also Vice Dean of Students Affairs. And now he's going to present to you the movie about how to make post and course clinically. For me, goodbye now.
Hello, dear students. Good day. I'm Dr. Hussein Ali Mahdouli from Tehran University of Medical Sciences, faculty member of Prosthodontics department. My topic is clinical guidance for making cusp, post, and core. And I'm going to show you a movie about cusp, post, and core treatment. Before starting any procedures, we must observe the teeth and evaluate from some parameters. For example, good apical seal must be present, no sensitivity to pressure, no exudate, no fistula, no apical sensitivity, and no active inflammation must be present. We can observe the perioptical radiograph and assess these parameters. For example, no lesional radiolucency at the end of the root, and good filling material, good apical seal, and so on. We must observe, and after that, we must decision to treat the teeth. In this case, central incisor, maxillary central incisor, I treat by post and core because large composite material filling was present in central and lateral incisor, and there is a high risk for corneal fracture. For starting of treatment, you must take an impression, primary impression, alginate impression to produce primary cast. Primary cast useful for us for diagnostic lacks of diagnostic assessing, and also for occlusion, we can assess the patient conditions. Discuss and produce from primary impression or documents for us, and we must save the primary cast. Therefore, we must take good impression from oral cavity and teeth. Before starting the treatment, we must notice to procedure we must do it. For cusp post preparation, we have two sections for treatment: coronal preparation or post space preparation, and coronal tissue preparation or crown part of this must be prepared. I started removing the composite material from access cavity and some endodontic material catapercial from canal, and after that I get a diagnostic PA radiograph. This is how the story begins, and because of a large composite filling material is present, that is high risk of fracture. But we must determine the length of post space. At the diagnostic radiograph, we can estimate the length of post space, and at least about 5 capture of internet. After removing the endodontic aperture, we can take an radiograph radical. That's the start. Before any preparation, I selected the prefabricated temporary crown and assigned it for next procedure. At first, I started by incisal preparation. I started preparation by incisal edge, and after that labial surface of central incisor, and we must follow the rules of tooth preparation. We can use guiding groove, and we must prepare margin. And because we must prepare for complete crown, and also we must remove the undercut from the access cavity, and because of old restoration, for example, enlarge of composite resin material, therefore result is thin wall and thin and unsupported enamel and dentin, and we must remove the unsupported enamel and dentin, and after that remainder of tooth tissue is known as ferrule. In this view, you can see ferrule tissue, and it's very important for prognosis of next restoration. But I decided to make custom-made cast post and cord by direct technique, by resin material, and at the first time you must prepare the canal and the tools. I selected plastic pin or double plastic pin or screw, you can choose, and we must check the length of post space and determine it on this plastic screw with rubber stop, and we checked it with file. After that, canal must be lubricated with some lubricant material. For example, I used Vaseline with cotton peel, and the canal of the tooth was lubricated because the resin pattern material may be locked in the canal. I used the Duralay resin material. Resin pattern is very good material for forming the resin post. The consistency of this material must be creamy, and also we can use brush technique. But start this with some spatula. We can add resin material on the plastic dowel pin and insert in the canal. And at this time, before full setting of material and stiffness of resin material, must be do pumping action, and we must reset and loosen and reset the post. I did the pumping action to prevent locking the post in the undercut of the canal, and I formed the excess of material. At this time, only we want to form post part of the resin model. We can observe the resin material, and we must check it again to ensure from complete setting of the post. Sometimes maybe need to reline the post and maybe some void on the post. At this time, we can reline the post. Again, must be recheck the length of post space, and after that, we can reline the resin material. At this time, we must use very low consistency of the pattern resin material, because if it will be stiff, it can cause to incomplete setting of the post and maybe shorten the post. Also, we must do pumping action and loosen and reset the post again until the material is set. After that, this stage, we must prepare the core, and we must build up the core of post. And by adding some acrylic material, we add on the coronal part of tooth, and I try to build the form of the core similar to peripheral teeth for time saving. After insurance of complete setting and building the core, we can starting to prepare the core part of the post, and also we must again recheck the post space length. I started the preparation of the core part of the post, similar to rules for tooth preparation, and we must consider the distance between incisal edge of the post from opposite teeth, and also we must consider thickness of future crown and the next restoration. It must be checked from occlusal surface and also palatal surface, and the distance from opposite teeth. And now it's ready to send to the lab. And after that, we must use the prefabricated temporary crown and must be made interim restoration for this. I use the prefabricated temporary crown, which selected before.
XP voice privacy contents have been updated. To continue, review the updated items on your screen.
Making temporary crown with prefabricated temporary crown, and after that, I use the prefabricated metallic post. This prefabricated metallic post, the dentators metallic post, we can use for retention of temporary crown. Distance from opposite teeth must be considered. At this time, we must making temporary crown, and I relined the temporary crown and metallic dentatus spin with relining resin material simultaneously. And after that, we must remove the excess of material, and also we must adjust the margin of temporary crown and form and contour of crown, because margin of crown is very important for us because it may be cause to inflammation for gingiva and recession. After that, we can terrain in the tooth and must be occlusion checked, and form and contour of crown must be adjusted. Sometimes maybe some void in the, for example, you see in the labial surface, and this void can be repaired with this resin pattern for temporary crown, and easily can be repaired and adjusted. After that, we must cement with temporary cement this temporary restoration, and also we must use temporary cement only on the margin of the crown. And after that, we must remove the excess of temporary cement, because cement may be caused to inflammation of gingiva, and we must ensure of cleaning the margin. And at next session, we must terrain the post, and before of that, we must remove the temporary crown with arch crown or crown remover instrument with slight strokes. And after that, we must clean the orifice of canal and must try the post. We must insert the post in the canal very slowly and with very light pressure or gentle pressure, because it may be to fracture or crack in the root. And I checked the post with light body material as pitch checker, and it can show to us, for example, premature contacts or some nodules maybe. With light pressure, we must put the post in the canal, and after setting the material, we can see premature contact, and we can mark this premature contact with some yellow pen, and after that we can remove these interferences with bird. I marked some nodules and some premature contact, and I removed those with bird. And after that, we must take a PA radiograph to evaluate the sitting of the post. And after that, the post is ready for cementation. And for cementation, we can choose some cement, and also we must prepare the root for cementation. The root must be clean from debris and lubricant material, and must be cleaned completely. I chosen the resin cement material Paneria F2. This cement has two liquid as primer, and after that, after mixing, must be applied on the root and on the tissue, coronal tissue of roots, and base and catalyst of cement must be mixed and applied only on the post. I use primer on the tooth. On the tissue surface, and after mixing the base and catalyst of the cement, it's applied only on the post part of the post and core, and after that we must insert the post very gently with light pressure or without pressure into the canal. At this time, you can see hydrostatic pressure because air is present in the canal, and we must, with gentle pressure and light pressure, insert the post and permit to escape the air and excess of cement from the canal. Because this cement is dual Q cement, we can remove the excess of cement very gently before light curing, and after that we can cure it with light. Any excess cement must be removed from the margin and finish the gingiva carefully. After that, I use the light cure for curing the total cement on the coronal part of the tooth. And again, we must completely remove the excess of cement. In palatal surface and mesial and distal surface, we must carefully remove the excess of cement. And after this time, we must make a temporary crown, and all temporary crown can be adjusted for this purpose, and must remove the metallic dental tooth pin from the prefabricated old temporary crown. And after that, we can reline the temporary crown with resin pattern temporary material. And in this stage, we must carefully remove the excess of material, and also we must do pumping action and loosen and reset the crown to prevent of interlocking the temporary crown on the post and coronal tissue of tooth. Removing the excess material before complete setting. After completely setting the material, we must adjust the margin of temporary crown, because the margin is very important for us and must be very fine to prevent any inflammation at the gingiva and recession. After that, we must cement it with temporary cement. And after that, we must remove the excess of temporary cement. Also, is important, similar to permanent cement, because temporary cement can cause, if remain in the gingiva, can cause to inflammation or some recession. Thank you for your attention, and next session, it's ready to taking final impression. Thank you very much for your attention. I'm ready for any question.
Thank you, Dr. Mokoli, for your nice movie and presentation. And there is a question, as it is asked, instead of impression, do you think digital scanning is better and faster? Do you prefer it? Digital
impression, no final impression. It didn't any final impression. Or scan is good. Instead of impression, do you think digital scanning is better and faster? Do you prefer it? For post is more difficult scanning, because there is a deeper space and a darker space, and scanning is not enough and not very good. And I prefer direct or indirect technique by impression. And casting process, I think, will be very easy and will be very useful.
But if perhaps he means that after cementing the post and core on the tooth, do you prefer scanning or taking direct impression?
Yes, after cementing the post is not difficult and not problem, and I prefer to scan if it's possible. Yes, it's very good, very better from conventional impression.
Any other questions? So,
thank you very much and for your attention, and thanks a lot for Dr. Farid for helpful lecture.
We will have a break for